Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. How are you?
Great. Saturday morning. It's finally fall here in St. Louis.
It's definitely
It's
fall.
clearly the weather has changed.
All right, you just broke up. Can you hear me?
Uh, I don't think there's anything. Yeah, I can hear you.
It's just half of what you said
Do you
didn't
want
come
me to
through.
switch over to my phone? Okay, do you want me to switch over?
I mean, I really don't, but I don't know what the. I mean, this shouldn't be a busy internet time. I mean, the question is,
No, nobody else is on
do
right
we
now.
need to pay to do this differently, where we everything's recorded locally and then uploaded? Fuck. All right, let's.
Let me try something.
Okay. Are your kids power streaming videos right now?
No, they're not power streaming.
You totally froze there. I don't know if that was intentional because of a switch.
Yeah, I'm switching over now to something else. Does
Okay.
that work?
It's
Am
working
I
now.
working okay?
Yeah.
Okay, let's try this.
Oh, hey, Chris.
Hey Chuck, how are you?
Fantastic. How are you?
Man, it's cold outside. It's like a solid, I don't know what it is in Celsius. I should know because I was just overseas, but it is a solid like 40, 50 degrees outside. It's chilly.
Yeah, it's too cold. I didn't bike into work yesterday or the day before because it was like 43, and that's below my acceptable limit.
What is your threshold?
Uh,
50?
Probably 50. It used to be 60, but I've gotten a little more daring.
I admire you for biking in. As everybody knows on the pod, I'm very risk averse now, and I just don't need any variability in my life in terms of unnecessary risk. Although I'm sure it's a beautiful bike ride in across Forest Park.
Oh, it's beautiful. It's beautiful. The last time I saw you was in Canada.
Yes, we were in Vancouver. We had a really fun time recording that live episode. Hopefully, people found it interesting and fun, and those that were in the audience, thank you for all of your energy and your engagement. It did make it, a really fun experience.
Yeah, it was fun, and yeah, hopefully we connected. It was great. It was great. And you mentioned you were have been traveling even more.
Yes, I think that my wife has a travel bug, and I love being married to her because I get to do all the fun things. And we were overseas. We were on holiday, as they say, in Italy, which was really fun. But all of this travel in October has led to some adjustments in my schedule, which have been a little bit crazy. And well, I guess we'll talk about some of those necessities later on in this episode in terms of finding time and ways to do things so as to not completely slow down your practice.
Absolutely. Yeah, as I think I've shared, my wife and I belatedly celebrated our 30th on the Amalfi Coast, which was a long-term sort of dream of ours to go visit, and it was fantastic. And I don't think anyone's ever had a bad trip to Italy, so I'm sure you guys had a great time.
Oh yeah, no, I came back very satiated in terms of food, and great experience. A lot of really fun places to see. We hadn't been to. We went to Sicily, which was really cool, and then spent a little time in Rome on the back end, which was fun. So
Sounds great. Sounds
yes,
great. Maybe we should start by thanking one of our sponsors. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand.
So we had talked about trying to lead off on each episode, talking about what we're going to talk about. So I guess we can do that now.
Yeah, so because of a number of things, including time away for various for conferences, this holiday, I've got a committee meeting I've got to go to. My OR time in the ambulatory surgery center has kind of disappeared for October. And in addition to that, there have been some I don't know if gerrymandering is the right term, but there's definitely been some adjustments to the block time that our colleagues at the on the hospital side have suggested and tried to make that have me a bit stressed out. So I'm trying to utilize rooms and I'm trying to get cases done. And being away is hard because you got to find ways to get stuff done without making people wait a terribly long amount of time. I think it's okay to wait a few months for a total joint replacement, but people aren't really trying to wait 4 or 5 months for their carpal tunnel release.
No,
Um,
that's exactly right. And the department's fighting, as you well know, for your rights to avoid gerrymandering.
Yeah, no, it's an interesting game, and those of you that have spent some time in St. Louis understand some of the the chess pieces. But I've had some interesting times where I've had a day of local only cases, all locals because they were able to find an OR, but they weren't able to find an anesthesia team. So I negotiated that I would do only local cases for an entire day, which honestly stressed me out a bit. How would you approach something like that? Have you ever done a full day of local only cases?
I have not. That's a lot. My general mental capacity is two to three, occasionally four, generally pretty small local cases. And so, yeah, that's at least from my perspective, not easy. I hope some of our listeners will disagree and share some of their thoughts, but I'd love to hear sort of what type of cases you did and how you made it work. And did you have a trainee with you? All those things are interesting.
Yeah, so to talk about what we're going to talk about today, we'll go into how that went, and then also little pearls that we use for cases, whether we do them under local, whether it's a little bit different. So, yeah, I mean, my normal OR day, I'll do up to four, maybe five locals, split between the two rooms to get the rooms started and get things flowing. I'll do all the blocks ahead of time before the first patient rolls back, and try to do the dance so that I'm just bopping back and forth for the first four cases. Everybody's blocked, everything's ready. And that's worked generally very well. But because of the needing to add another day and doing only local cases, I honestly was like, I don't know if I have the mental ability to do this many local cases in a single day because it's exhausting. I think it's exhausting. Now, clearly, we're still, at least at our place, still doing these cases in the OR, which I think we're behind compared to a lot of other facilities where a lot of surgeons are doing these cases in the office. And I think ultimately we want to get there.
Well, let's start with that conversation. Local only cases in the OR versus the office. And so, my perspective is this from a physician perspective, it's great doing it in the operating room in the sense that we just continue our current routine.
Hmm.
We have amazing help and it's low burden as far as the all the stuff around the surgery. I would think that most of us would agree it's not necessarily perfect for the patient. There likely is a facility fee charged by the operating room, which at least in our situation is not able to be charged for the clinic, and probably just a little more of a hassle factor, although honestly not a big hassle factor to do it in the operating room. What other factors do you think about in office versus OR for these type of cases?
I
Oh,
don't know if I lost you there or
you froze. I don't know
I
if I
froze.
froze too. I guess I must have. Did you hear my question?
No, you were talking about the last thing I caught was facility. Hold on, it's because it switched me back to the other network.
Um, okay. I don't know. Oh, you're frozen again. Fuck. You're back.
Yeah, can you hear me?
I can now.
Hold on one second.
If you're talking to me, I can't hear you.
Sorry, I had it hotspotting off of something else and then it switched over in between. So the last thing I heard from you, and if this happens again, we can try to figure out something else. But the last thing I heard from you was about starting into facility fees and that we can't charge one at our place.
Okay. Let me try to just start off. Yeah, it might not be ideal for patients, or it certainly is not ideal for patients in the sense of they likely will have a facility fee charge when a procedure is done in the operating room. In our situation, that can't be charged in the clinic. Um, and so, from a patient perspective, I don't know if they really care about the location other than what it might cost them. The rigmarole around a formal outpatient surgery versus a clinic-based surgery probably not very different. We all know the cost to the system and to the insurers and maybe to the patient, depending on out-of-pocket expense, is also far greater in the operating room. What other factors do you think about from a OR versus clinic setting?
Well, I think the facility fee is probably the biggest thing because obviously there need to be some kind of overhead costs that are built into having the equipment, sterilizing said equipment, buying the sutures, et cetera. So that needs to be built in somewhere. It's just obviously as as you've pointed out, we have struggled to actually make a facility fee work with the current situation that we're in, and there's a lot of that's very specific to our institution. Hopefully we can find a way to make that work because I know a lot of places have a procedure room or an in-office procedure room or even a hospital procedure room probably is cheaper. But the facility fee is hefty, and then for hospitals and facility for institutions, that lost income, while we don't think these cases are huge, it's going to add up.
Yeah, I don't know how many carpal tunnels, triggers, ganglions, Dupuytren's, mucus cyst excisions our division of 8 going on 9 surgeons does annually, but it's a real number. And we do have a major new facility coming on board in a year where we're going to have a dedicated procedure room. And my goal for that procedure room, which will be in our clinic space, is that we have a plan and a flow that maybe once a month Chuck has a half day or a whole day or whatever it is to do these cases, and maybe we just alternate, during those days, and we really hit that hard and efficiently. But it'll take some logistics, and it would be very, very nice if it came with a slightly higher compensation, not just surgeon fees. And as I understand some of the changes coming down nationally that you probably understand at least as well as I do, that likely is happening. And so I think this will end up working out, even if our contracts with certain payers don't necessarily provide any incentive for us to transition to clinic-based surgery.
Yeah, it's interesting. I don't think there's any incentive because the stuff that we do is a relatively low cost point compared to things like total hip and total knee arthroplasty, spine surgeries, et cetera. I think obviously the value efforts and cost containment efforts are largely based on those high volume, high cost type procedures. I think another consideration about procedure room versus operating room is do you have the right equipment? Do you have what you need in terms of lighting? Which I think when we had our dalliance with in-office surgeries during the one of the COVID shutdowns, lighting was a big issue. Even though we just pulled the trays from the OR because nobody was using them, et cetera. And then, I think there's the question about do you need full on, sterile field, et cetera? I think there are a lot of places that have moved away from a full on sterile field and have, really stripped down the needs in terms of, both cost and environmentally, drapes and gowns, et cetera.
Yeah, there are ways to be efficient, and if we are able to pull this off, we will need to learn specifics from our peers because we both are aware of generalities, but we want to create a flow that works. And again, it's crazy. When we were dallying during COVID, we looked into disposable sets as well, which just fundamentally bothers me. 25 bucks gets you a nice basic set that works perfectly fine for simple surgeries, and then you throw them away, which is a crazy to me that you can get reasonable instruments that are disposable for $25 and just feels wrong.
Right. And honestly, the instruments aren't as good. Like
They're
they're
not.
fine. They're fine, but they're not as good. Like it's the stuff that if you're a trainee, like you're working with in the ER, those kind of packs, like they're not that good. And it doesn't feel the same. Yes, it can be done. It does feel wasteful. Um, I was talking to a colleague, one of our colleagues who's at a big, private center in the southeast, and he was talking about how he did 24 carpal tunnels in a day, and I'm like, oh, like that's a half day, I think, just based on his procedure room. I'm like, sounds awesome, sounds awful, like in the same breath, because it's like I don't know if I could do that many. I love it from an efficiency perspective. I think it's great, and I'm sure there are ways to make it fun and engaging, but that's just not something I thought about.
Yeah, well, it's this discussion of Wallant or local only cases has continued to be a real popular topic at the Hand Society annual meeting and other meetings. And you and I would not claim that we are, experts in this area. We certainly do it, and I think we do it well, but we're not cutting edge. I'll put it that way. What are your ideal cases for local only surgery, both from just a simplicity standpoint, but perhaps also the next level, where is it advantageous for you to think about doing a local only case?
I think default local only is carpal tunnels, triggers, the Quer veins, mucus cysts. Um, Advantageous, I think, for trigger finger. I think it's just easier. Like, I don't love doing a traction tenolysis in general, and if I don't have to, that's great. And I like engaging the patient and showing them that. So I think that is helpful in terms of, do you ever have to do an FDS slip excision, et cetera? It's come up every now and then, very rarely, but it comes up. And I think that telling the patient what you're doing is super helpful and efficient because you don't have to have the conversation later. And then other things that I've found it advantageous, I think for tenolyses, if you can, make them comfortable enough for something like an extensor tenolysis, super helpful. Flexor tenolysis, I think, is a little bit can be trickier. Extensor tendon repairs are great, wide awake, local only. I think that is a home run for sure when it comes up. Doesn't come up that often, but like a zone five extensor tendon repair is awesome awake. And then honestly, it's easier to add the case on too. Like I've done a number of zone five extensor tendons at the end of the day after clinic, just saying, hey, it's local. Could I just like pop over and do this case? If you're doing that, mark the patient while they're in the office, so you don't have to go over and mark the patient again later while you're trying to finish clinic. Just a little pearl. And then I think where it's been really nice, and this came up on that day that I was doing local onlys, was I like doing it when patients are just older and you don't feel good about offering. You think a surgery is going to be helpful, but you don't want to expose them to any sort of sedation, even if it's 10 minutes of Mac local, that kind of thing. But nonagenarian, nonagenarian, yeah, and an octogenarian with carpal tunnel. You think you could make them sleep better, like that's going to be helpful. And then I had somebody with a foot drop who I've done probably 3 or 4 common perineal nerve decompressions under Willant, which
Wow.
always raises eyebrows, but it works really well.
Wow, that's very cool. I love the concept of just frank safety. That is no one could ever argue that it's not a safer intervention with local only, and that's usually where I get the patients to agree because some of them don't want to. And I will say there's still maybe 1 out of 10 that I can't convince, and maybe I should just say it's this way or no way, but probably 90% will agree for those basic cases that you outlined to do local only. And in, Missouri, we have our share of high BMI patients where I would have to go to the main hospital to do a carpal tunnel, which is not acceptable to me. So those I push. I basically insist that those be done as outpatients, local only.
Yeah, I used to really push people towards local only, and I've stopped pushing them. If I tell them it's going to cost more, you've got the IV, you've got the anesthesia hangover, somebody needs to bring you here, bring you home, etc. And the thought of local only freaks a lot of people out. I then when they say they don't want it, I kind of make it an opt-out situation for like a carpal or a trigger or a curvates. I'm like, we usually do this under local. People are really comfortable, et cetera. If you really feel like you want sedation, you can certainly have that. Here are the reasons why I think it'd be better for you to do it under local. But I'm not pushing after that. Like I used to be like, all right, well, this is how we're doing it. And now I'm like, I just don't have the energy to have that conversation anymore.
Yeah, I wouldn't argue with that at all. And my flow works either way. So my flow is that I do little cases that involve anesthesia first, and I used to have a ton of them. Now I sometimes have none or have 1 or 2, and I start my day with those, do my cases, and I end the day at anesthesia's request with the local onlys. That's a little trickier than the process you described because I can't just necessarily numb them all up. And if I'm running ahead, then are they going to get there early enough? So it works. It's just it's fine, but your flow is probably better in that regard.
And I kind of happened onto that flow just because I used to do it the way that you did it at anesthesia's request, so they could send their people home. But then the nursing situation changed where they actually had more nurses at the beginning of the day, and at least at our place, and this gets to like the burden of doing it in an OR. Apparently the AORN requirements are that you have to have a nurse monitoring the patient during any local procedure, even if it's completely awake, which I think is ridiculous. I've tried to fight this battle and decided my energy was better spent elsewhere. But they still require a separate nurse to go in, and they just have more nurses at the beginning of the day. So they've now asked me to do my locals at the beginning of the day.
Yeah, makes sense. So one of the cases that I have done local on, and actually I think I have one this week, is Dupuytren's. And I've done that for 2 reasons. So first of all, I've done just small Dupuytren surgeries where there's an isolated cord, nothing crazy, because that is not what I want to do. Meaning a really challenging Dupuytren's, I wouldn't want an inadvertent patient movement or discussion where all of my attention is focused. But simple Dupuytren's, I don't really do nodule excisions, but simple cord excisions I think are fine, especially in the palm. And those have been fine. I have once or twice done more than I would like under local only for Dupuytren's. So I'm curious to your experience with Dupuytren's, and I'd like to talk about one of the payer challenges we're having with Dupuytren's.
I don't like doing dupes under local just because I think there's just enough variability in how that case can go. Maybe with the kind of exception that you're saying, like a pure isolated central cord where you can't do it with a needle, and you want to do a partial fasciectomy. Um, I just think that there could be so many things that could go in a different way, and then usually it's fine. And maybe I'll change my tune in a couple of years, but I just prefer to have the patients asleep for that one. You could do it under a beer block, I think, typically, if you're thinking it's a relatively small case, which I think makes it a little bit easier.
Yeah, no argument, no argument. Interestingly, I do a fair number of needle procedures or needle episiotomies. I don't think we've mentioned it on the pod, but we have a continued issue with one of our payers, both straight commercial and Medicare Advantage with the commercial attachment, where they will not pay for in-office needle procedures for Dupuytren's, which I've had several conversations with the medical director, and just that they don't offer a rational explanation, but they won't do it. And those are really frustrating to do in the operating room, just because it's completely unnecessary. It's honestly crazy and driving the cost up for no reason. I don't know if you've done any needles in the operating room, or it's just not really your practice mix.
I've done one, and the nurse was like, "Why are you doing this in the operating room?" And I said, "Well, that's that guy's insurance company." So, it's frustrating. And I think that's just one of the downsides amongst the many upsides of American healthcare. Just when you have commercial insurers that control how things are done, this is just what's going to happen.
Yeah. Maybe I'd like to hear your perspective on teaching under local only, but maybe we should thank our other sponsor first.
As hand surgeons, we know that symptomatic postoperative adhesions after nerve and tendon repair result in postoperative pain, loss of range of motion, and the need for revision surgery.
Checkpoint Surgical's newest product, ACM Shield Soft Tissue Barrier, ACM Shield Soft Tissue Barrier, is a temporary protective barrier that creates a supportive environment that aids in the prevention of symptomatic postoperative adhesions in nerve and tendon repair procedures. To learn more and to read it yourself, visit checkpointsurgical.com.
But that would have been a good one, as a segue for the tenolysis portion of the Volant procedures. But we should think ahead next time.
For sure. All right. So when you have a local only case, the patient's wide awake. I introduced my resident or fellow to the patient. I do try to create a visual barrier, and then I do a lot of whispering and things. So tell me how you think about educating in a local only case.
I mean, most people choose to have the drape. I ask people every time you want to watch, and like probably one out of 15 or 20 says yes. I still kind of do the same thing, to be honest with you. The knife is, typically still in the trainee's hands. Now, say the barrier is up and the monitoring nurse is talking to the patient. There's a lot of pointing. You'll ask, there are certain, I think we've talked about this many years ago. So, if you're a dedicated listener, you may remember this conversation, but there are certain words we don't say when patients are awake. You don't say knife, you don't say scalpel, you don't say incision, you don't say oops, you don't say sorry. Um,
You don't cluck.
you don't exactly. And then typically the trainee is pretty silent, and I'm just kind of talking through things. So I will, say 15, and then I will point to the trainee. Typically, the scrub nurse already knows to hand the scalpel to the trainee. We'll, say it's like a carpal tunnel. The dissection continues as normal. If it's somebody that I've worked with for a while, they already kind of know the procedure. We're just adjusting retractors, et cetera, and they can call for retractors and everything. But oftentimes it'll be like, okay, so now, even though the scalpel is in the trainee's hands, I'll say, now I'm dissecting through the superficial palmar fascia. Now I'm going to adjust it with retractor. So now we're exposing our transverse carpal ligament, and I'm feeling for my hook of the hamate. It's kind of like you're just talking somebody through the procedure, but you're just saying that I am doing it. That tends to work pretty well. And like typically the trainee, because most of our trainees are pretty well adjusted and normal people, will introduce themselves to the patient as they're doing the prep and drape, et cetera, maybe make some small talk. because I'm typically coming over from the other room or finishing, orders or whatever. So and then, depending on kind of where they're at, I mean, typically like, the trainees doing the suturing and I typically will do the dressing, et cetera, because I send them to the other room while I'm waiting for the Dermabond to dry, which is a painful 2 minutes or whatever it is. So I don't know. I think that's how I've approached teaching with it. I still feel like they need to be getting the reps, and understanding how this is a little bit different from when you do it with the tourniquet on.
Well, all good points. I'd add two things to this. Number one, if it's a physician surgeon I'm not super familiar with and hadn't done five carpal tunnels with, then I will discuss it with them outside the room briefly, the steps and the things you just said, which was well encapsulated. And I think that it's also a really important part of hand surgery in 2025. And so to not expose residents and fellows to a robust experience in local only surgery is doing them a disservice. Not that it's hard to learn, but it should be part of a educational process. So it's really important.
Yeah, odds are they're going to be doing this in practice. So, I think that there are people who express a particular interest in making it work in their practice. They'll come out, they'll watch the blocks, they'll kind of ask about the workflow things that you and I just talked about. And you can obviously pick it up and figure out your system on your own, as both of us did. Um, I don't think anything becomes terribly harder with, doing it volant from a technical perspective for like a carpal or a trigger, because I think both of those surgeries are about, very deft retraction, as opposed to, I think that the tourniquet is a nice gift for the small little vessels, but typically the epi takes care of a lot of that stuff at the superficial level. One thing I found a little bit trickier is just retraction of the fat pad surrounding Guillaume's canal, on the ulnar side of the carpal tunnel incision, just because I tend to make my incision a little more ulnar than most people, intentionally. And that just becomes a little trickier. So I've switched from using a Sen retractor, on the ulnar side to using a Baby Army Navy, the smaller end of that, which I think if you have that in your tray is a really helpful and still small enough to fit into a mini open incision. It's just because you don't have like the openings in the Sen in the blunt, or the rake end of the Sen. Because you don't have those openings, it's bigger than the broad end or bigger than the blunt end. So it's nice to retract all that fat back.
Yeah, so for those listeners who haven't done a lot of these, my typical, and I think Chris's typical, is two sens and a Ragnell retractor. In a patient who has a lot of fatty tissue, I sometimes go up to the next level, which is a what we call a finger loop long, which is like a Ragnell, but just a little longer, a little wider. And then the next level up is the Baby Army Navy, which I would say, despite our population in Missouri, I use, I don't know, 3 times a year. It's very uncommon. Not that I do a lot of carpal tunnels anymore, but just not common. But it's a great tool when it's necessary.
Yeah, I don't think I have a figure loop long in my sets at the surgery center, which obviously it's available at other places. It's just a necessity of what's been available. And then I think I don't know how you do this. We talked about this on the pod before. I close now glabrous incisions with a foromonocrol deep dermal. And one of our trainees put me onto a particular needle, the P3 needle, which has probably the right curvature to for deep dermal closure on the glabrous skin. I moved away from nylons, and we talked about that on our live episode a couple of weeks ago.
Yeah, I still like nylons, and I'll give you some. I have a question and a comment. So my comment is, I recently had a surgery which ended up being a pretty long 7 centimeter incision in my forearm, and they closed it with a few deep dermals and a running non-absorbable. It was great, and I'm not here to be critical at all. And in fact, I asked for a stronger skin layer just because I wanted to get back to activities faster. A running non-absorbable is a pain to take out, right? I think so. Those should be avoided in general. And again, I knew what I was getting into, and one of my great residents took them out, and it was no problem. The problem with deep dermals is what I'm living with now is that for some patients, it's irritating and you get a little reaction. And sometimes they spit. And so that's why I don't like them. I just like nylon. And I recognize, except for in kids, and then I use an absorbable. I use a five or four Vicryl repeat a lot. In adults, I don't. And I understand why you do. For me, it's just simpler to use a nylon.
Yeah, no, I used a PDS, a Fora PDS, and at one point, and that was very reactive, which is weird because that's supposed to be the least reactive suture, but it was super reactive. And then switching to a Fora monocrol has been I think helpful. Have moved to using for like when we're doing our crazy plexus stuff. we'll do a deep dermal layer, and then I'll do just running 4O monocryl, like you would do for a non-absorbable, but just running it like a baseball stitch, which I think has been very efficient. And some of those harvesting sites are just inconvenient for sutural and staple removal, et cetera. So
Yeah, three comments. Got to have three. Haven't done three in a while. So
yes,
number one,
as we come to a close.
as we come to a close, number one, um, can't remember number one. Um, number two and three. So, having had a few surgeries from different specialists, a couple things were interesting to me. Number one, really not number one because I can't remember number
This is
one.
number 2A.
This is two and three. First of all, I Chuck Goldfarb allows my patients to get their wound wet with nylons for like a carpal tunnel or trigger at day three. These other specialties allowed me to get my wound wet on day two. Not soaking, not scrubbing, but day two, which made me feel better about day three, and I may transition to day two. So I'd love your comment on that. And the second point of this is they also stress emphatically, and this is plastics and derm, to keep the wounds moist, and that's with Aquaphor or Vaseline. And I've yet to decide whether I think it helps, but they were both adamant. Both those specialists were adamant about keeping it moist the whole way through. And I'm sure some of our listeners from a plastics background would agree that's not the orthopedic way typically. So, how do you
Mm-mm.
think about timing of suture removal when you have non-absorbables and the whole moist versus dry?
I think wounds can get wet at day 3. And I think I switched to that. I used to be day 5. And
Okay.
then I heard you switching to day 3. So I switched to day 3 because clearly you've thought about it. I feel much better about it because I tell the patients, look, we're going to have some skin glue on there. Like most people aren't reactive to the Dermabond or whatever skin adhesive you use, if you're liking. But occasionally some people do. So as before I put it on, I ask them, hey, have you ever had a reaction to something like this, etc. Um, and then I use a dry dressing on top of that. So I use a Telfa, like a non-adherent dressing, and I tell them to keep it dry. I don't tell them to keep it wet or moist. I will use Vaseline as part of scar massage and to help wear away some of that dermabond after the first post-op visit.
Why don't you let them get it wet on day zero with Thermobond?
I guess I could, but I don't know. I'd like to slow people down.
That's great.
I mean, it's just
Yeah, I'm not being critical. I'm just
yeah, no,
curious.
I mean, I think that if you give them an inch, they take a mile. And I think having the dressing on for 3 days is a nice reminder to take it easy. But yeah, clearly, I think you're right. I mean, I haven't thought about it that much, but yeah, I would let people get nylons wet at 3 days too.
When I do a hip donor or a lower extremity donor site, and I use Dermabond, I let them get that wet on day one. I remember what number one was now, and I think I've said this before. My favorite suture, literally type of technique, is the running horizontal mattress suture. I
Oh
think
yeah.
it accomplishes everything that a running baseball does, but it looks better, it everts, and it's still fast. So I love that, especially obviously with an absorbable suture.
Whenever I use it, I say this is what Goldfarb and Wall use.
Love it.
So
Probably a
there
good
was
way
some
to.
kind of there was some kind of stitch that the foot and ankle surgeons used at my residency that I think was very similar. They called it like the Texas two-step, but it was essentially a running horizontal mattress, which I think is super nice. So yeah. All right. So, if listeners, if you have pearls about Wallant and teaching and how you've incorporated maybe office-based procedures, please tell us because clearly we need to be educated because as Chuck mentioned, we've got a big facility coming on board in a year and we're still in the stage where we can make some adjustments, hopefully, to workflow and planning. Please let us know, handpodcast@gmail.com.
Love it. That was fun. Thank you.
Thank you.